healthcare is a reflection of how people have viewed each other socially in the past. And you can see that obviously in South Africa, with the way the system is set up for white people and black people, the legacy of apartheid. You can even see it in the US, how it's set up differently between the northern states and the southern states in the US before the Civil War, when they were fighting over the abolishment of slavery. In healthcare, the more you pay, the less you get. Nowhere do you go where something like 30 or $40 billion is spent in South Africa alone on healthcare. Nowhere else do you go where $40 billion is spent every year and it's never paid by the consumer. In South Africa, say 60 million people, 9 million people have medical scheme cover and can afford private healthcare. 51 million people can't afford private healthcare and have to go to government.
I hear the problem you're solving. You're essentially trying to lower the cost of healthcare.
Yes. While maintaining quality, if not improving quality.
Yeah.
Premiums on health insurance products, medical scheme plans have been going up 10-12% per year, and inflation has been half or less than half that. I don't mind if Healthforce is never a unicorn. I'm trying to solve a fundamental healthcare problem. There was a 60-year-old man living in Leboa in Limpopo. He went to the government clinic. He had a skin condition. Sure. So that guy never left Leboa. He saw a nurse in Leboa, a GP in Cape Town, got advice from a doctor in America, all in the space of 45 minutes, and it cost him at that time around 175 Rand for that whole experience.
Sure. What other opportunities can young people look forward to?
I think we're going to see young people coming in being able to drive that consumer-led growth in healthcare, building products, engineers, designers, product people, taking to market, your social influencers, your marketers. I think the other thing for young people coming into healthcare is this AI augmentation that's going to increasingly happen. People had a doctor that lived in Kamchatka, which is the peninsula in Russia that borders Japan. He was working on a mine there, and at daytime he worked in the mine, at nighttime he logged in and worked on Healthforce.
Wow.
So it doesn't matter where you are in the world, you just need to be registered to work in South Africa.
But you were able to build a business case, backed by angel investors already. How do you do that?
Welcome to Behind the Industry, the podcast that pulls back the curtain on the fastest growing industries shaping our world today. Our mission is simple. It's to empower young people with knowledge, context, and inspiration to make informed decisions about their futures. So whether you're in high school, newly graduated, navigating an internship, pivoting a career, or starting your own new business, this podcast is for you. In this episode, we're diving into the powerful world of digital health, an industry that's not only transforming healthcare access, but also creating new career paths and entrepreneurial opportunities. Our guest is Saul Kornik, a pioneer in Africa's health tech space and the founder and CEO of two game-changing companies, Healthforce and Gena Health. He's reimagining how we access healthcare, making it more affordable, more scalable, and more inclusive. We'll explore the problems Saul set out to solve in healthcare, the role of AI in healthcare, the future of nurses and doctors, and how young people can break into this evolving industry, how to build, fund, and scale tech-enabled businesses in Africa, and why making healthcare accessible is one of the most urgent business missions of our time. This episode is packed with powerful insights for anyone who wants to build, contribute, or lead in a purpose-driven industry. Let's take you behind the scenes of the businesses that are disrupting and redefining healthcare. This episode is brought to you by Doorways.
Did you ever think you would do what you're doing now? When you were younger, did you ever think you would be in healthcare, you would be in social impact?
How much younger? Like at school?
Maybe when you were 18.
No.
Because you kind of think you know stuff by then.
When I was 18, I knew nothing. But I also knew I knew nothing. I had no idea what I wanted to do.
So at which point did it click that you are drawn to socially committed, you're drawn to socially conscious businesses? Because if I look at your life, you've spent a lot of time in socially conscious stuff than not socially conscious stuff.
Yeah, I suppose it depends how you define socially conscious, but involvement, certainly healthcare has an impact on the individuals in society and has an impact on society at large. I didn't think I'd get involved in healthcare specifically. I ended up involved in healthcare when I was looking at a number of different opportunities, many outside of healthcare. And then healthcare, I've stuck in healthcare because it's is an intractable problem in the healthcare system that I find really fascinating, that I learn about all the time, and that I've developed enough expertise in that I can meaningfully apply myself to try to solve at least parts of the problem. And then it's an intractable problem because healthcare is a reflection of how people have viewed each other socially in the past. And you can see that obviously in South Africa with the way the system is set up for white people and black people, the legacy of apartheid. You can even see it in the US, how it's set up differently between the northern states and the southern states in the US from before the Civil War, when they were fighting over the abolishment of slavery. So that makes it quite complicated. It's also not a normal market. It's not a normal market for three reasons. The first is the more you pay, the less you get. Nowhere else do you pay more and get less. You can go buy more car, you get more car. But in healthcare, the more you pay at a system level, often the less you get. And a classic example is maternity. And you end up in private sector South Africa being looked after by a specialist obstetrician, where 20% of the time you might need that obstetrician based on the statistics. And the other 80% of the time you could be looked after by a nurse a midwife at a much lower cost. And when you're looked after a midwife, you're much more likely to have a cesarean section. Sorry, you're much more likely to have a natural vaginal delivery, which is much lower cost. And the recovery time for natural vaginal delivery is, well, you can have a baby, literally pick up the baby
in the afternoon. Yes,
exactly. And it's very low risk to the baby if it's a healthy pregnancy, and very low risk to the mother if it's a healthy pregnancy. And in the other 20% of the cases where it's high risk, of course, you need that specialist intervention. But in the private sector South Africa, and we were speaking before this, I know that you and other women predominantly go to these specialists to be looked after. And there you're going to get a cesarean section because that's what the specialist is trained to do. They deem it to be the safest. They're not available 24 hours a day. So if you give birth in the middle of the night, they're not available then. It's much more convenient and safer to schedule it at a time when they're available to ensure that the birth happens in the right way. And so 80% of the time you end up having a cesarean section, paying for a theatre, paying for a anaesthetist, paying for the specialist obstetrician, paying for 4 nights in the hospital, 6 weeks of recovery. So it's much more expensive, and actually you get less for it because you end up taking a massive risk for yourself and for the baby with such a serious operation. You've had one before, I was too. It's not for sissies. It's not. Yeah. So that's a classic example in healthcare. The more you pay, the less you get. That's the one reason. The second reason why healthcare is quite different is there's a bigger information asymmetry between the provider of the service and the consumer of the service than in any other sector. The doctor knows a lot more. The patient knows very little. And if you went to your obstetrician today and he or she did a scan and said, oh, maybe there's a water on the brain for your little baby, we better take the baby out right now. Unlike if you were buying a second-hand car, you would go check with my uncle. Let me go check with, you'd say, no, take the baby out now.
Yes.
So the information asymmetry means that you often have to just follow the doctor's advice with very little information yourself. And then the third reason why the healthcare sector is very different, in my opinion, is that nowhere do you go where something like $30 or $40 billion is spent in South Africa alone on healthcare. Nowhere else do you go where $40 billion is spent every year and it's never paid by the consumer, or very little at the time. It's paid by government, it's paid by Discovery, it's paid by Bonitas, it's paid by the medical schemes. So in an environment where there's a third-party player, you get what the third-party player is willing to provide. So you're not getting necessarily what you need as the consumer of healthcare, you're getting what the payer is able to pay for, willing to pay for, deems appropriate to pay for. So it makes it a very different sector as well. And so these things come together in South Africa in an environment where it's completely underregulated to create some incredible healthcare organizations in the private sector, in the hospital side and the funder side, with GPs and specialists and so on, but where the incentives aren't necessarily always aligned, actually very seldom aligned to what the customer needs. And that creates problems in health outcomes and escalating costs and people not being able to afford and so on.
That last one is very interesting because when you say it out loud, if you say that the government pays a large portion, it sort of feels okay. It feels like it's a social issue. It should be driven by government or by NGOs. It feels like it's its natural setting. But you're saying no, it shouldn't be like that.
No, what I'm saying is that the healthcare sector is complicated by the fact that the government pays what it's able to, what it's willing to,
Yes.
deems appropriate,
Yes.
rather than the consumer choosing what is best for the consumer. And nowhere else. If usually what happens if you go again and buy a car, or if you buy a laptop,
You sit
buy
with
a
the
house,
power. Yeah.
you choose what to buy because it's your money, and so you get what you want much more often. In healthcare, where you've got the government paying, you will get what the government's able to provide, and that's very much the case. In one of my previous companies, I was running an organization that recruited doctors for rural hospitals. So I visited pretty much all the rural hospitals in South Africa, and we could see there, although that's often with how the government was able to set up those services, or willing to set up those services, didn't always meet the needs of the community around them. But yet that's what the community then had to consume as its healthcare service. And so, it's not just the government pays for some of, government pays for all of healthcare for about 50, 51, 52 million South Africans. So it's a significant portion of the country that doesn't get to choose something that's better for them. They get to choose what's is given by a third-party payer.
When you identified these three problems, did you feel Healthforce was going to solve them? Is that how you landed up starting Healthforce?
I don't think they're problems.
Okay.
I mean, I think they are characteristics of the healthcare sector that make it quite unique. The reason why the purpose behind Healthforce is essentially that in South Africa, say 60 million people, 9 million people have medical scheme cover and can afford private healthcare. 51 million people can't afford private healthcare and have to go to government. Having visited a lot of government hospitals, I can see that funding for government facilities, sometimes the management of those facilities is poor, and so government is falling short in terms of being able to deliver the healthcare that people need. Often health outcomes are poor, patient experience is poor, and this is for the vast majority of the 51 million people. And so the result is that that these people are stuck with that as the only option for their healthcare. For the 9 million people, on the other hand, like, why can't the 51 million people access the 9 million people have? Well, it's just too expensive. And it's too expensive for a number of reasons. I think one of the main drivers behind the expense in the private sector that makes it unaffordable for the 51 million people is that private sector healthcare providers are paid on a fee-for-service basis. So this means that they are paid for effort, they are paid for volume, they're not paid for outcomes. So while I think there are so many, the vast majority of healthcare providers in the private sector that are really trying to do good things for their patients, they will always tend to doing more than what's necessary because they're getting paid for that effort by a discovery, for example, and that pushes up the costs of delivering healthcare. It's called overservicing. I do more than what's needed. In addition, when I make money from you as my patient, as a GP, for example, or as an obstetrician, as an example, as a hospital, as an example, I don't want you to go somewhere else. So I hold on to your information, which means, and I don't want to work with anyone else in case you choose a different obstetrician. So it creates fragmentation in the healthcare system. And then when you choose to go to a different provider, that provider doesn't have your health record, they will often quite happily duplicate the effort of the previous provider, both because in a fee-for-service environment, they make the money from doing so, but also because they have no option but to duplicate because the health information is not shared because of the fragmentation, because people are holding on to their income streams. And so the consequence is that expenses go up and up and up and spiral much faster than inflation. I mean, premiums on health insurance products, like medical scheme plans, have been going up 10-12% per year, and inflation has been half or less than half that. And that's the reason why. And so we've got the situation where private healthcare doesn't necessarily always deliver the best outcomes. The example maternity is one. But it's certainly better than public sector, but it's too expensive for most people. So the reason why like Healthforce exists, and for that matter, Kenna Health as well, is how do we reconstruct from first principles the private sector service in such a way that the cost of that service drops to the point where it's affordable to not 9 million, but 19, 29, 39, 49, eventually 59 million people, so that all South Africans can have access to private sector care. And that's essentially the problem that we're trying to solve.
And okay, so I hear the problem you're solving. You're essentially trying to lower the cost of healthcare.
Yes. While maintaining quality, if not improving quality.
Yeah.
Because access is not just impacted by cost, it's also impacted by quality. If you're a young woman, teenage woman, and you go to a government clinic and the nurse chastises you, verbally abuses you, sometimes even physically abuses you because as a teenager you got pregnant, you're unlikely to go back for your future checks there. So the quality of the experience also determines the extent to which you will return. Not just if you're treated badly, but if you go somewhere and it didn't help, you won't go back again. So we want to not just lower the cost, but actually improve the quality. And we have actually managed to do that.
So what does Healthforce actually do?
What does Healthforce do? So how do you solve this problem? How do you make healthcare lower cost,
but good experience,
higher quality, but in the private sector? And the fundamental way...
Why keep it in the private sector?
Because it's very slow and hard to move the way government operates.
Okay.
I think government's movement will hopefully come through the way they want to organize healthcare to be funded through the NHI. That'll incentivize healthcare to be delivered differently. And even if NHI doesn't happen, there will be certain regulations that come in as on the back of the NHI thinking that will hopefully shift the entire healthcare system to measuring outcomes, providing primary care rather than specialized care to keep people out of hospitals, the sort of things that are driving up the costs. But private sector, you can move much quicker. You can test things out that hopefully position yourself in the future that if an NHI fund wants to fund every South African to have access to quality primary care, in our example, we will be able to be funded to do so. So yeah, difficult to move government. I don't have the patience for it. And I think that private sector can actually become affordable to the vast majority of South Africans.
All right. So let's go back.
So how do we do it? The way we do it, and this is not my idea. This has been tried out by a number of healthcare systems around the world and been written about by many people. But essentially, you've got to organize a team of healthcare workers, and you've got to organize that team around the need of the patient. So let's break that down. What does a team of healthcare workers mean? A team of healthcare workers means that you've got different disciplines for different issues that cost different amounts per unit of their time. A unit of a nurse's time is much a lower cost than a unit of a GP's time, is much lower cost than a unit of an obstetrician's time, is much lower cost than a pediatric oncologist's time. So how do you bring together a team that can deal with everything, but where you've got the lowest cost unit available based on what the patient needs? And only when the patient needs a higher cost unit does the patient go to that higher cost unit, and only then for the amount of time needed by that higher cost unit. So that's what I mean by a team. And what I mean organized around the need of the patient, it means that we've got to have data about the patient from the specialist insights of different kinds of clinicians and from the patient themselves and maybe from their wearables. We've got to have this data that we can then use to establish what the patient needs to feel better. They may come in for a blood pressure, but what do they actually need? They don't want to walk out with a blood pressure. They think they have hypertension. They think the blood pressure is causing them to have a headache.
Discomfort, yeah.
So, but they actually want to feel better. So the more data we have and the more different kind of skills we have to look at that data, the more we're able to help that patient feel better. And so what we've built in Healthforce is the following. It's a clinic practice management system, which means it's a piece of software that nurses use in their clinics to run their clinics. The software organizes that consultation for the nurse, prompts that consultation for the nurse in such a way that they collect data, holistic data about the patient, not to provide the individual service like the blood pressure the patient came in for, but looks at that patient during that encounter in the most holistic possible way, with decision support to make sure they collect all the necessary data. It There's an e-learning platform that trains nurses up to do top-of-scope care. And only where the nurse can't then help the patient in that environment, in that system, providing a attendance certificate for the clinic, a recommendation letter for medications to collect and so on. Only when they can't do something that's in their scope of practice do they then click a button on the Healthforce system, and without having made a booking, on average 3 minutes later, one of our GPs will appear on a flat screen TV in the clinic room. And that GP can see the patient and nurse. The GP then enters into a consultation with the nurse for the patient and can provide a sick note, a referral letter, or a prescription as the patient may need. But because the nurse has done the bulk of the consultation, we only need a few minutes of the GP's time. The GP doesn't have to do the medical history. The GP doesn't have to collect information. In fact, the GP asks the nurse, what do you think is going on here? And then builds off that, so it's a team. 15% of the time you need the GP. GP's time is less. GP's time is much less expensive. The other 85% of the time you're paying for the nurse at 100 Rand, significantly lower costs. So overall, if you go to these clinics that Healthforce supports, you will pay on average 45 to 55% less than if you went to the GP every single time.
And that's how much?
Well,
Roundabouts.
So our biggest partner, much biggest partner is Dis-Chem. So you won't see Healthforce in Dis-Chem. You'll see it branded as Clinic Connect. It's a fantastic service that Dis-Chem has. Dis-Chem has probably the best network of primary care nurses in the country, best qualified per clinic, and the broadest network nationwide. And those nurses use our software. And a consultation with a nurse in a Dis-Chem clinic can range from somewhere between, I'm going to get the pricing wrong, somewhere between 100 to 150 Rand, somewhere around there.
That's quite affordable.
It's very affordable. And then only then, when that nurse can't help you, and often our GPs are also training the nurses in the background so they don't call the GPs unnecessarily, only when the nurse can't help does the nurse then call the GP. And the cost of the GP at that point can vary. We've got certain conditions we can do very quickly and some that take a bit slower. So the GP consult might cost you on top of, let's say 100 might cost you another 120 Rand, up to another 260 Rand, depending. But if you think about what it costs to go to your local suburban GP here at 700, 750 Rand, that's a significant saving. And we can do the same level of care, and the quality of that care we've measured is better than anything that's published. So for example, we've got a 76 net promoter score rating in Dis-Chem clinics. Well, Dis-Chem clinics have a net promoter score, should I say, of 76. That's the service that their nurses provide in combination with our doctors. Now, 76 out of 100 NPS is significant. The average NPS for healthcare services in the US is somewhere between 0 and 5.
Okay.
And the highest published NPS I've seen for a healthcare company in South Africa that I've found is Bonitas, which is 36. So we more than twice that. So the customer experience is really good. You're paying much less. It's much more convenient because you can pop across to your local shopping center during a lunchtime. So yeah, we've improved a lot in reducing cost and improving the quality of the service.
So you started Healthforce in 2018. When you started it, obviously you had identified the problems or the challenges that you've mentioned now. How did you know that this was the best model that you could create for this country? So how did you validate your idea? How did you know that I can put my time behind this idea?
Yes. So first thing I must say is the conversation we're having now is a conversation more than 7 years after having started this. So over that time, I've learned a lot. I'm continually learning. And so I'm able to articulate our position much more clearly now than I would have at the start. By no means was I this clear on what we were trying to solve back then. It's never the case. Any entrepreneurial journey, you kind of don't really know what you're doing at the start. You've got an inkling that something here might work. Maybe you've got a bugbear about a particular issue. And so I just want to be clear, like, this is not a straight line. I had this idea, we've built it, and it's been straight.
Yeah.
There have been many decisions we've made which have been wrong. There are many assumptions that we made that we tested that were wrong. So yeah, the reason for our existence and what we've built to date is a function of a lot of learning, not just from me, but from a team of people with all sorts of expertise. Product engineering expertise, marketing expertise, clinical expertise, customer success, call center people, finance, how do you build organizations, people function, analytics, data, and so on. But at least when it started out being funded by some investors that were buying up small independent pharmacies and creating a chain out of them. And they also invested then in establishing Healthforce. And I was like, we built the software for their clinic rooms in their pharmacies to see if patients would come in and see a doctor there at a lower price.
So see a doctor virtually.
See the doctor virtually with the nurse. Same basic model I've described. And so, in terms of kind of developing the product and validating the idea, we were very lucky that we first off established we needed a crucible in which to test. And these investors in this pharmacy group were very innovative and forward-thinking, and they think in forward-thinking, and that allowed us to then test in their space. We built a system first up that was designed by a doctor, and the nurses wouldn't use it.
Oh.
They wouldn't use it because although it captured everything we know that clinically was sound, that a doctor needed to do a doctor level consultation, we weren't able to defeat our biggest competitor. So I don't know if you know who our biggest competitor was.
Who's your biggest competitor?
A piece of paper. Yeah, that is our biggest competitor. Nurses just kept on going back to the paper they'd using because it was simple, even though we saw some bizarre storage techniques like nurses filing patient records by the condition they last came for. Instead of by names. And the patient would come in and they'd have to say, what were you here last year? I think there was a cough, or maybe it was flu. They'd look under cough, they'd look under flu. So we saw some bizarre things. But the problem was with a complicated user interface, even though it did the job, was that nurses wouldn't actually use it. And so I learned a very hard lesson up front that you've got to start with user experience. So we brought in some of the best user experience people in the country. Some of them actually both of them are still involved today. And we come to understanding of how do we beat this competitor with a piece of paper? How do we make this simpler than a piece of paper, but also help the nurse with the problems that paper filing has? So that was kind of one of the first things that we learned in validating this product. Once we built something that is so simple to use, it is like a piece of paper, but it has the advantages of storage and search and seeing past medical records and being able to upload information to a discovery, for example. We then proceeded, we didn't even have telemedicine at that stage. We then proceeded to then try telemedicine, different queuing systems, different mechanisms of the doctor engaging. And so over time, we learned more and more and more. But each time we decided to build the next thing, we go through a particular process to do so. We talk to users. We don't ask them, would you use this? We try and understand the problem that they need to solve. We prototype, test out whether that solves their problem or not. We experiment. We measure whether those experiments are working. If the experiments are working, then we double down and invest a little bit more in seeing if we can take that particular feature a little bit further. And once we see, yes, it's going to work, then we make the big investment of engineering time to then go and build that out. And slowly the product has evolved over time in that way. Not just validating the concept of the nurse and doctor working together, which we were fortunate enough to do early on, but advancing that in such a way that it becomes a better patient experience, health outcomes can improve. We're linking to funders, we're doing wellness consults, we're improving the decisions that clinicians are able to make through that same kind of product development process of experimentation, fast, low-cost, measurable experiments, and making sure that it's focused around the user and what the user is willing to use, and always making sure that we're not just addressing customer value, but there's a business case for what we're doing too. Because if there's no business case, then we are an NGO. And we want this thing to scale. We want to reach 50 million South Africans. We've got to make sure that the business earns a margin and can scale with that.
When you mentioned a lot of iterations, all I think of is that's a lot of funding going into this before you make money. And you mentioned the business case has to make sense. So I'm guessing at this point, you're just throwing money into this thing, trying out different things, but you're not really getting anything. Who's funding all of this?
At the start?
Yes.
Well, it was two private investors, a family office and a private individual. You'd probably, I suppose, in the stage we're at, you'd call them angel investors. They had a risk appetite to do this. They saw
Were they doctors? Were they?
No, they weren't, but they were investing in this pharmacy chain. So they'd built an understanding of the healthcare system. So they were pretty amazing to invest in this and to be open-minded enough to test this out and continue investing in it. And as it started gaining traction, And we actually had a number of suitors, a number of companies that wanted to buy them out. And our biggest customer at the time, after their pharmacy chain, was Dis-Chem. And Dis-Chem ended up buying them out and taking a majority stake in Healthforce. So now Dis-Chem actually owns a majority stake in Healthforce.
Healthforce.
Yeah. And they've continued to fund our innovations and our development. And of course, having the testing ground of their pharmacies with the quality of their nurses has been second to none.
So I'm guessing at a point when people started lining up wanting to buy out these angel investors, you knew this is the business I need to focus on. You knew it was going to be big.
Look, I think when you can measure that the quality of the customer experience is better than it is elsewhere, and the cost is 50% lower than elsewhere, and you can see that people are using it, and you can see that certain people would be very unhappy if you didn't exist anymore, so you've got a product market fit there. You're making enough margin at the right volume, you've got a sustainable business. Those are the ingredients that come together quite nicely to mean that you've got something that people want. So I felt pretty confident, given the kinds of companies that were approaching us, that we were able to extend the funding in such a way that we could continue developing the product into what it is today. But the best strategic match was with Dis-Chem. And so that's why we ended up going with them, courting them, and then they invested.
Oh, so many nuggets there. So my first question is, most people struggle with raising funding, especially right at the beginning.
Yes.
But you managed to get angel investors right at the beginning. So is it something, and I'm asking this question also knowing that you've also gotten funding for Gainer Health. You also got funding for NGOs back in the day. So it seems like it's your thing. You're very good at getting funding.
Okay.
Yeah, it's your thing. Own it. How do you do it? Because one of the things entrepreneurs struggle with, especially in South Africa, they feel they're not in Silicon Valley, so they feel like, where do I go if I'm looking for funding? But you were able to build a business case, backed by angel investors already. How do you do that? What's your strategy when it comes to raising funding?
So maybe I am good at talking to investors. I have in part, I've got a finance background myself. But I think that most of the time why investors seem to be attracted, not all investors are, but investors seem attracted to the businesses that I've been involved in, is because of the conviction I have, the passion I have, and the energy that I'm putting into these ventures. And the track record I have so far of building multiple things, which super helps a lot. So I think if you really believe in what you're doing and what you're not believing in, I've heard people talk about their startups like the objective of my startup is to become a unicorn.
Yeah,
that's not a unicorn. I don't mind if Healthforce is never a unicorn. I'm trying to solve a fundamental healthcare problem. And we're actually now trying to solve a fundamental problem because this organization is filled with people that are also imbued with this purpose and are happy to come together every day and work in the discomfort of a startup, working really hard with high risks to continue pursuing that purpose. So I think conviction, my track record, which only comes after some period of time, the team that I've built around me, high quality individuals. When we've had investors coming in, they come and they meet the team, and that often sells them on the business as well. It's not just a one-man show. I think the other thing is that I'm fortunate that I've got a network. I'm a privileged white guy, and actually the way I connected it to, you don't say, and one of the ways in which I raised funding for Healthforce at the start, actually the way that I got to the angel investors was through somebody that I knew socially, somebody else who had worked with my brother at another company. And so I started talking to them, and that's kind of where the idea arose and the funding for it arose. So, it's very difficult, for example, I see these kids from a local township who have a brilliant idea, and I wonder how they're ever going to be taken seriously, how they're going to get to build a track record, how they're going to get the network that they need to unlock the door for their idea, for their passion, for their ability. So I think there's a lot of that in it as well. And then, look, I think there's certain aspects of how you present your business to a funder that can be more or less appealing. I think they've got to understand that it's not just about a purpose, but there's a viable business here. They've got to kick the tires on that and make sure that it's realistic. They test your thinking to see how you would get around certain problems that might arise. And so thinking deeply about something, having discussed it internally, having debated it a lot, having tested certain things and seen them fail, allows anyone raising funds to have a more informed discussion. I think one attribute that I have is that I'm also quite clear in my thinking, unless this interview sounds a bit garbled to people listening. I don't know.
Let us judge that.
Yeah, let them judge that. But certainly I'm prepared enough when I go into these discussions to be crystal clear about like what it is that I'm asking for and why I would put my money behind it if I had that money.
So now you decided to create Healthforce. There was a lot of backing and all of that. In my mind, it seems like you had gotten to the root of the challenges. Why then start Kena Health? Why not just expand Healthforce and integrate this new virtual experience that you provide with Kena Health? Why start Kena Health?
I think first reason is the investors in Healthforce weren't interested at the time in having a purely virtual service, which is what Kena is. So let me just explain what Kena Health is, where Healthforce is a piece of software run by nurses in clinic rooms that allows them to call in a virtual doctor. Kena Health takes that experience purely into the virtual environment. So you can download our app from the iOS or a Google Play Store. The Apple Store or the Google Play Store. We also a web app. You can go to kena.health or web.kena.health and access our service from there. And then when you enter into the app, I think our average, it's 1 minute 30 seconds on average to register. It's very quick. You can go in before you even buy anything. There's Explorer mode where you can see how it works, which we found really helps people to understand before they have to spend money on the service. But once you're in, essentially you get access to a nurse, a GP and a mental health professional, and you get to see any combination of those that you need to deal with the issue at hand. So often you'll find people coming in for a mental health consultation and the mental health professional will realize that there's some way in which this mental health condition is manifesting physically. They refer you to the doctor, or likewise the doctor might refer to the mental health professional where there's a psychological component to whatever the physical ailment is. So no matter who you see, we have got that price point down to 75% cheaper than your local GP.
Sure.
Yeah.
So even lower.
Even lower than the physical virtual, that hybrid physical virtual environment. There are reasons for that. You can take less of a clinician's time. When you're sitting with a nurse, it just takes more time. The nurse in a physical environment is able to do more, but there's an equipment costs and the consumables cost in a nurse environment. But there's a remarkable amount you can do in a purely virtual environment. Now, we're able to do repeat prescriptions for chronic drugs, contraceptives. We're doing weight loss consultations now around GLP-1s if they're necessary. Those like Ozempic type drugs, although Ozempic is not allowed to be prescribed for weight loss in South Africa right now. We are able to do your colds, your flu, your coughs, the stomach bugs, the gastro going around. We're able to provide advice on many things. We're able to requisition pathology results now for you. We go to Empath. We've got a discount at Empath. We get the results back and we can help you with that. We can give you a prescription. We can give you a sick note. We can give you a referral letter. 95% of the time we're actually able to help patients with the conditions they come for. So that's what this app now does. So why did we start this outside of Healthforce? Well, the investors in Healthforce at the time didn't want to invest in a purely virtual play. So we went and sought investors elsewhere. We found investors out of Sweden who had invested in a similar purely virtual service in Brazil. They were very happy to invest in something similar in South Africa. So they were essentially our seed investors, our angel investors at the time. And that's evolved over time now. And we've got some pretty incredible investors on our cap table now. Some of the biggest corporates in South Africa are invested and starting to use our product as an adjacent service to their existing offerings. But that's how we ended up setting Kena up. Healthforce also has an equity stake in Kena, and that equity stake wasn't given to Healthforce based on a financial investment. Rather, the equity stake in Healthforce wasn't provided to Healthforce through a financial investment. Rather, Healthforce has shared a lot of its IP around virtual healthcare, around the clinical protocols, around how the back-end technology works in exchange for that equity stake. So that was the way we still leveraged the lessons we learned out of Healthforce into creating Kena. So that when we launched Kena, it didn't look like people that started launching a telemedicine app for the first time. It rather looked like something that was
Yes.
evolved through 4 years of lessons learned already.
So it seems like you were going up sort of like a value chain. So you started with hybrid model, got your cost a little bit lower, then you went completely virtual, got the cost even lower. Okay, is there like a AI machine learning third components that Kena is sort of okay, or you're gonna call it something else now? You get my question?
Yeah, I
So
get your
is there a point where we lower it even further using AI, machine learning, all of that, or do you feel no, we still have runway with virtual only? So it Kena.
No, I don't think you can do anything without AI now. So firstly, let me say that there's two ways to answer this question. The first way is this. If you think about the way we're trying to tackle this cost and quality problem, we're tackling both cost and quality by making sure there's a team of healthcare workers organized around the need of the patient. That team might be a nurse, a doctor, and a mental health professional on Kena, or a nurse and doctor in a Dis-Chem clinic, but there's still a team there. Part of that team is the technology, though. There are things that the technology really does to hand off between the clinicians, decision support. And if you augment that technology with the capabilities of generative AI, it can become a much more meaningful player in that team. And again, if you're looking at shifting tasks to the cheapest possible player in that team,
Could be the tech.
although there's an investment in the AI, that investment is increasingly coming down. That tech can play a bigger role, which means you need less of the nurse's time, less of the doctor's time. We can bring the cost down even further. And we can actually augment the nurse and doctor in such a way that they are still making the individual clinical decisions, but with this incredible support in the background of an AI tool that helps them to think things through, not miss things they might have missed, to pick up things that are missing. So there's definitely a role for AI to play if you think about team-based healthcare. Around the need of the patient, again, AI can look at the data and better interpret that data so we can understand the patient better. So it plays a role in the entire system of how to lower the cost of care. The second way to look at it is like this. If you think about AI, or generative AI as a tool that's generally available in the world. Right now, well, say 3 years ago, we had human beings working as creatively, as constructively, as best they could to develop products for customers. Now we've got this artificial intelligence that augments human beings. So you've got two groups of human beings now working in the world. You've got human beings that are augmented with AI, and you've got human beings that aren't. We're already augmented with technology. I mean, everyone walks around to touch their phones like this, right? So you're already augmented with technology, but this augmentation is second to none. Who do you think builds a better product at the lowest cost, the human or the human augmented with AI? Of course, the human augmented with AI. And so the other way to look at this AI thing is, even if it isn't part of the team, and even if it doesn't help to identify the need of the patient better, it's still a requirement that we augment ourselves with AI so that we remain as competitive as a team, as an organization in the world, because otherwise we will be disintermediated by someone that does this more efficiently through AI. Those people that don't and fall behind and eventually fall out of the game, you'll be left with those people who have successfully augmented themselves with AI. From there, the people that use that AI the best will be determined by those who have their own proprietary data that no one's got access to, that the AI can use, maybe domain knowledge that they've got that other people don't have, so AI can be applied in a particular way, and distribution channels to get your product that's augmented by AI and your people that are building that product augmented AI more into market. And so distribution channels are critical on a product like ours. We've got the distribution channel for Healthforce through Dis-Chem. Distribution channels on Kena that we're now securing is we've got Old Mutual as investors. So we're now going to be using Kena Health as a healthcare offering in combination with some of the products that Old Mutual sells, which is fantastic. And we've also secured...
What does that mean?
So what it means is that, for example, you can imagine Old Mutual's got an employee benefit proposition. But they don't have a healthcare offering as part of that. They now add that service onto that offering so that the employees they support aren't just getting financial wellness counseling, they're not just getting retirement benefits, they're now also getting access to healthcare services.
So essentially a company could subsidize the employees' healthcare.
They could subsidize or just make it available to employees
even
because it's a lower cost,
availability.
or
Yeah.
we're partnering, for example, with a company that does earned wage access, allow employees to consult with Kenna and just have it automatically deducted off their wages or their salary at the end of the week or the end of the month.
I mentioned you're very good at raising money, but you're also very good at securing partnerships. I mean, you've spoken about Old Mutual, you've spoken about Dis-Chem.
You also see us in Checkers stores, and they're starting to market us, and you'll see ShopRite marketing us soon. And we hope to build that partnership out in more meaningful ways in time.
So how do you identify the right partners? Because again, as I mentioned, you mentioned the youngsters from the township that don't have access to funding. Another thing they struggle with is partnerships. Okay, how do you identify when you decided to get a partner for Healthforce? How did you handle it? How do you list them? How do you reach them?
Yes.
What do you prioritize? Yeah.
So Healthforce.
Don't say you're a privileged white guy.
I mean, I am, but look, Healthforce was interesting. We were approached by people from medical schemes. We were approached by people from hospitals and as potential partners. I don't know if I made the right decision or if we made the right decision at the time, but we chose not to partner with a medical scheme to be owned by them, because then we would have been locked into serving medical scheme members predominantly.
Look at you not choosing money, choosing the cause.
Well, in part choosing the cause, but also in part realizing that at a low cost, if we really want to build low cost healthcare, we need volumes, because there's very little margin per consult. So
And
although it's
with the
short
medical
term,
aid.
they could have driven to us. In the long term, we don't just want your 100,000 or million medical, we want 50 million people. So it's also a good business decision too.
Yeah.
But you're right, it's also a good customer decision.
Yeah.
We didn't think hospital was the right partner in that sense, because hospitals, the predominant way that hospital makes money is through something called paid patient days. It's the number of days that patients are in their beds at a hospital. It's like a hotel.
If it fits your business model.
We don't want it. We want to keep people out of hospital. And so to use this as a customer acquisition channel to fill your beds seemed like counterproductive to the reason why we started this thing in the first place. And so we looked around and said, we are reliant on a partner. Who is the partner in South Africa that is most forward-looking with respect to trying to serve people in medical schemes, and also those people who don't have medical scheme cover? And essentially, there are a number of clinic networks in the country. Clicks has got a smaller one. I don't know if their nurses are trained to the same level as Dis-Chems. There's Unjani clinics, which are fascinating, really beautiful such setup where nurses can build their own clinics funded by donor funding that then run for their communities. Is amazing. And then there was Dis-Chem. And when we looked at it, well, Dis-Chem is, you can see some of the marketing out there. They are talking about them becoming like a better health starts here. They have this ambition to become a meaningful healthcare provider, and that lines up with our vision. They want to serve the kind of market that we want to serve. It lined up with our vision. So there's a huge amount of strategic alignment there. And so Dis-Chem was the one. In my first meeting with Dis-Chem, I went with my co-founder, and we were actually pretty much chucked out of the meeting because we didn't know what we were talking about, and I don't know, the meeting didn't go very well. So there's also a degree of persistence you've got to have. That person, when maybe wasn't happy with us, we found that I think what happened was a different person, a senior person in Dis-Chem, saw us somewhere, mentioned to somebody they'd seen also in this other pharmacy, and then got hold of us because they wanted to see how it worked. So persistence and looking for that moment, and then making sure you break that door down when the opportunity opens up, has been critically important. On Kenna, we've been strategic as well.
Wow.
We know that, again, if you're a direct consumer product, like Kenna is, Healthforce is a B2B product. You'll be selling it to Dis-Chem, who then promotes the Connect service to their customers. Kenna, where you're going directly to consumer, no matter how low you get the cost of customer acquisition for a consumer, where you need the volume of customers we need to have a viable business, millions and millions of customers, you need a huge amount of investment to do the marketing to acquire those. And so while we went direct to consumer and we continue to go direct to consumer now, it is mainly to test our product, build up a track record, and make sure it works. The way we really need to grow, though, is through low-cost customer acquisition. And so we've sought out strategic partners who can take us to their customer bases at almost zero cost to us and at benefit to themselves. So that's why a partnership like, for example, with Old Mutual is so valuable to us, because it's valuable to them and we can acquire their customers at almost no cost to us.
So, Saul, you mentioned this, Kim. You mentioned the other clinics, clinic networks as well. Townships. How are you going to penetrate that market? And not just from a business sense, but also really from a social impact perspective, because that's kind of where we need the low cost primary care.
Absolutely. So we work not just with this, we work with a number of independent pharmacies. And some of those pharmacies are in townships or in lower income areas. And Healthforce remains open to partnering with any pharmacy in those areas or any clinic network in those areas. I think the better way that we reach into the townships right now is through the Kenna app. It's a low data app. You don't even have to download it. You can use it as a web app. And then we've made sure to optimize the usage of data once you're in the app. We will hopefully do data free soon, so you won't even have to use data when using the app.
That would be amazing.
The kind of partners we're looking at are partners that are looking, for example, Old Mutual, we're partnering with them and taking this to blue collar workers. The more we can get into being marketed through ShopRite, that's our their customer base is very much our customer base. If we look at the direct to consumer marketing we're very much targeting your young township mom who that can't afford to take the day off to go to the clinic, can't afford to wait in that queue and doesn't want to be treated that way, but still has a little money out of pocket to spend on healthcare. So Kenna is really, although we're finding 20% of our customers are still medical scheme members because it's much more convenient. Often if you've got a medical scheme, you're on a hospital plan, so you can't go to the doctor anyway. You've got to pay out of pocket, so it's much more cost effective. We're finding that the vast majority of the people that are using us represent the kind of market who we aimed to serve. And look, I think once the early adopters pick it up, then it becomes more ubiquitously understood because people don't understand what we do, and the brand becomes more trusted because right now we're a new brand. You'll find that our ability to reach into a township market, into a rural area, will only become that much stronger.
Your business model is basically centered around doctors and nurses, or just healthcare professionals in general. As you're thinking about expansion and as you think about growing, are you worried about supply of doctors and nurses, and how are you going to solve that?
It's a very good question. Because of the way we structure our service, we actually need doctors. In Kenna, we only need doctors, let's say 10% of the time. And when we need the doctor, we only need the doctor for much less time than if they were doing the consultation themselves. So we actually don't need that many doctors to serve a hell of a lot of people. Plus, doctors really like working on Healthforce and really like working on Kenna. They don't have to build a practice themselves. We bring them the patients. We've got a doctor that takes his holiday every year in Nature's Valley, sets up his tent with a solar panel and consults from his tent. So it's flexible. We've got a lot of working mothers who work with us. They can't afford to spend the time building a practice, but they can schedule their sessions with us around their availability. So in addition to that, we pay really well, like very competitive rates. And then the other reason why doctors really like working with us is because they can work in a team. If you start a practice, you're very isolated. To my point earlier, when you're a doctor, you don't want to work with the doctor next door because you don't want to lose your patients to them. You don't have a nurse because you're doing all the work yourself. They're now in an environment where they're communicating with other doctors, they're working together as a team, they're working with nurses, they're working with mental health professionals. It's a very stimulating environment. We set it up so they're doing continual professional development. We're giving them performance management. We're doing virtual ward rounds. They can learn what's going on. So that's really beneficial to the doctors. I think actually the last reason why doctors really like us, and they cite this often, is that when you're working in Bryanston or you're working in Claremont, you're going to see the illnesses of that area, the colds and flu seasons.
In this scenario,
First patient might be a patient with HIV from the Eastern Cape, then it might be a man with a rare skin condition in rural Limpopo, then it might be someone from Bryanston. So the diversity of what you get to see when you operate through our platforms is much greater.
In terms of other opportunities in healthcare and Kenna Health, because right now we've identified the healthcare professionals essentially. What other opportunities can young people look forward to? Because you've kind of created this new I won't say new industry. You've kind of expanded the healthcare industry. You've now brought in the tech side of it. So you've made it bigger for young people to participate in it. So what are some of the opportunities in healthcare and Gena Health that are now open to young people? So when young people think about the healthcare value chain, they can start dreaming of other things outside of the traditional medical professionals. Yeah.
Yes. I think we're seeing a shift in healthcare. There's a couple of trends. The one trend in healthcare is it's becoming much more consumer-driven. For years, we've been able to read news from anywhere in the world, not just the local newspaper like it used to be. We've been able to buy whatever shoe we want, not just the shoe stocked in the local shoe store. People are used to making decisions around their health and consuming what they want. Although there still is this information asymmetry where when you get sick, you've got to trust the doctor. There's so much of healthcare that you already know. You get hay fever at a certain time of the year. Flu season, you know what's going around your kids' school when they come back with a stomach bug and the flu. You know what you need.
The runny nose.
If you're a woman, you know you just need a repeat contraceptive. If you're on a chronic medication, you know you need a repeat chronic script. There's so much that where people can actually choose, and especially on the preventative side, keeping themselves well, there's so much that people can choose that they weren't able to choose before. And I think we're going to see young people coming in being able to drive that consumer-led growth in healthcare, building products, engineers, designers, product people, taking to market your social influencers, your marketers, products, speaking to consumers about the choices they've got and building for consumers the things they can choose. And I think that's the big opportunity, one of the big opportunities coming into healthcare. I think the other thing for young people coming into healthcare is this AI augmentation that's going to increasingly happen. And I think people that are involved in that space, and you don't need to be a specialist in technology development to be involved there. I think that's going to be another place where young people can get involved. And I think for young health professionals coming in, there's going to be an increasing need for nurses for lower levels of the less specialized levels of the, should I say, of the healthcare system to do more of the work as technology facilitates them being productive and allowing them to connect to specialists in time. So I think your less specialized levels of healthcare workers, there's a lot of opportunity there for nurses, registered counselors, lay health workers, dietitians, which is actually a bit more senior. But you're going to see a lot of opportunities in the healthcare space for them.
And you only hire South African doctors.
We only hire doctors that are registered to work in South Africa. So we have, for example, had a doctor that lived in Kamchatka, which is the peninsula in Russia that borders Japan. He was working on a mine there, and at daytime he worked on the mine, and nighttime he logged in and worked on Healthforce. Wow. So it doesn't matter where you are in the world, you just need to be registered to work in South Africa. So we're very compliant with the Health Act, the regulations of the HPCSA, the regulations of the Nursing Council. We just make sure we're compliant with all of those regulations.
You know, I was talking to you before we started the episode. I was telling you that one of the things my mom struggles with is she has to travel about 2 hours to go see her rheumatoid arthritis specialist. And my grandfather-in-law, he's in his 90s and he hates seeing doctors. So it seems like the best solution would be to get, a virtual consultation. What are some of the success stories that you've had where you've really seen how virtual tech or how virtual consultations have really changed the game?
So I'll give you two stories. The first is there was a 60-year-old man living in Leboa in Limpopo. He went to the government clinic. He had a skin condition. There was a long queue standing in the sun, no doctor in the clinic. So he decided he'd spend a little bit of money. He went to the local pharmacy. The nurse that took a look at him didn't know what was going on. So I said, can I call the virtual doctor? Took some pictures, uploaded it. The GP was sitting in Cape Town. The GP in Cape Town looked at this and went, I'm not sure about this, but I've got a dermatologist that I know in the US. Let me send the picture to them and see what they think. The dermatologist confirmed that this was a rare skin condition called pemphigus. The GP in Cape Town prescribed the medication. The nurse printed out the script for that man in Leboa. He went and collected his medication. Problem was solved. So that guy never left Leboa. He saw a nurse in Leboa, a GP in Cape Town, got advice from a doctor in America, all in the space of 45 minutes, and it cost him at that time around 175 Rand for that whole experience.
Sure.
That same week, we treated one of the CEOs of the big listed companies in South Africa at a clinic in Bryanston. That GP, that that person saw the same GP in Cape Town on the same system, same quality of healthcare.
Oh,
One example.
you
Second
level
exa-
the playing field. Wow.
Yeah, you do in that way. And
Yeah.
look, I mean, the clinic in Le Bryanston was a much more fancy clinic, and tiles were nicer. And
Yeah.
maybe, I don't know,
The outcome.
the outcome was the same, and the quality of the service, the engagement would have been the same. Another example is there was a little girl who came in with an abscess on her eye, and she was at risk of losing her sight. And usually with an abscess, what you've got to do is you've actually got an operation to drain it. But there was no, they're far from a hospital, and there are risks with that operation as well, and it's expensive if you want to go to private sector. So the nurse there called one of our doctors, and that doctor knew about this trial drug that they were using to deal with this, that was prescribing off script of an existing drug, and they trialed it out, and the abscess went away. So there we helped a little girl not to lose her sight without having to go and do this operation, either very expensive or at risk to her. And that's another example of how we were able to help someone.
Gena Health app won the 2023 MTN Business App Award.
Yes.
Congratulations.
Thanks.
When I saw that, the first thing I thought of is, how much does it cost to build an app like Gena?
Sure. Today or when you built it? Because today you can ask Claude to build it for you and then just debug it.
That is so true.
Yeah. Yeah.
Okay, back then, the real number, the number you felt.
So look, if I had to rebuild it today, even back then, I could build it at a fraction of the cost that I built it, that we built it at today. The reason is because we built a whole lot of things that never got used. We had to rebuild things, we had to redesign things because it wasn't working, and that's the nature when you're building a product. So I think when it comes to building a piece of technology, a consumer-facing app, as an example of one, you've got to factor in the cost of the iterations that are going to have to happen. There are ways to reduce those costs: prototyping, experimenting in small ways before you invest in a lot of engineering time. But inevitably, it's going to cost you more than the straight line of this is the end result, and you build the end result. But you're looking at, it's expensive. You're looking at millions and millions of rands. You're not looking at, not looking at a few thousand rand here. Although today, I think you could probably do it for like significantly less, under R1 million.
Really?
I think if you have the right engineer using the right tools, I think the game has completely changed. There's this interesting practice that's arisen called vibe coding. And vibe coding is actually where people are going onto Claude, going onto ChatGPT, using products like Replit, and building little apps for themselves through plain language prompts that do things for themselves, even if they're not taking it to market. And so you're finding people, just everyday people, building little apps to help them out in everyday life. And the opportunity to expand that into kind of bigger product development is already there.
And did you struggle to find talent in South Africa, especially?
No, there's lots of talent in South Africa. I think the trick is we're very picky. We've got a very particular kind of person we're looking for. The people that work here give a very high employee engagement score, but they have a very low eNPS score, which means they don't think this is a place for everyone to work, even though they like working here. So we're very, very picky about the people we choose, and the people we choose fit with our culture, fit with our ways of working, fit into the team they join. And so a lot of the problem in hiring people was just finding people with the right fit. And that's one big problem. And the second thing is, of course, you've got to find someone who's willing to live the startup life.
Yes.
It's not just the founder that lives the startup life.
It's everyone.
I mean, as we sit here today, my team is grafting as a team to achieve a particular milestone we need for one of our funders. Everyone lives that stress, and I'm very transparent in how I lead. I want people to know where we stand. I don't want anything to be a surprise. I want them to be engaged. But with that comes a level of stress of being part of a startup. And so you've got to find the people that have the resilience for that, that have the passion for what we do, the purpose for what we do. Otherwise, they won't get through those difficult times.
And as a CEO of 2 companies, what keeps you awake at night right now?
Right now, today, there are lots of things that could keep me awake.
What's the one thing? Is it money? Is it the people? Is it the regulations?
No. So I think the biggest stress and from a lot of people that I know that have started companies and in a position, one of the biggest stresses is cash flow. Yeah. Even if you have a product that's working, cash flow delays for launches, investing in stock, cash flow is a major one. And then the second one is not that it's a second order priority, probably equal to that, is people. The cash flow is linked to people. I'm less concerned about cash flow if it didn't have an impact on my team and our ability to do our work and paying salaries. But certainly, like the stress of like knowing what the people are going through to build this product, and how to best support them, how best to structure things around them, it's front and center a lot of the time for me.
Thanks all for your time. I think Gena Health and Healthforce are really dealing with the crux of some of the healthcare issues we have in the country. And, we appreciate any product that lowers the cost of anything, especially healthcare, because it's so ridiculously expensive. So we know that adoption is a big issue, but we're just looking forward to more and more people using it, not just to lower the cost, but as you said, to also elevate the experience of healthcare, because right now we're paying more but getting less. And as you said, that it should be the other way around. We should be paying less and getting more. So thank you for your time.